Really great to see this room filled with those that are committed to the issues of gender equality and women. And my name is Dr. Rupa Dutt. I'm the Executive Director of Women in Global Health. And on behalf of Women in Global Health and IDRC, we are particularly excited to kick off this conversation. I'm going to begin with some welcoming remarks. And then I'm going to be turning to moderator Dr. Maria Nera, who needs no introduction in this room. And I know we're all very eager to hear from her as well. But the purpose of today's conversation is also to hear from all of you in the room on this agenda. So we're here to talk about climate and health, but about women on the front lines of disaster risk reduction. And that's really what's going to ground today's discussion. Particularly, I want to highlight that when it comes to this particular age, ours is unfortunately in an age when there are humanitarian disasters, crises taking place. We are witnessing, unlike ever before, wildfires, flooding, heat waves, hurricanes have become a norm. And when we start seeing the scale and frequency of disasters, that sets a new record in devastation. The WHO, sitting right next to the WHO, tells us that 3.6 billion people already live in areas of highly susceptible to climate change. That's nearly half of the people on the planet. Between 2030 and 2050, climate change is expected to cause approximately 250,000 additional deaths per year from undernutrition, malaria, diarrhea, and heat stress alone. The connection between health and disaster risk reduction is crystal clear. At Women in Global Health, we launched in 2015, and we've grown rapidly to have over 51 national chapters, mostly in low and middle income countries. Our chapter members are adamant that climate change and health must be a priority for our movement because they are already dealing with its impacts. I'm delighted to say you'll be hearing from many of them on today's roundtable. The women in our movement are very much on the front lines of disaster risk reduction. Women and girls are part of the vulnerable populations, part is hit by the dual climate and health crisis, and part of the 20 million of the 26 million people estimated to have been displaced by climate change already. Due to the gendered nature of societies and the roles men and women occupy, they do not have experienced climate change and disasters in the same way. Unequal distribution of power and resources along gender lines means women and girls are often most impacted by a disaster and come last in accessing via health services. More women drowned in the Pakistan floods than men because they had never been taught how to swim. Women, however, are more than health service users in disasters. They are also the agents of change. Women make up 70% of the health workforce, 90% of frontline health workers during crises and health emergencies, such as the COVID-19 pandemic. Women in health work the extra shifts, deliver the babies, make do with limited resources, and often put their own health at risk to keep everyone else safe in a disaster. And they do this in a form of unequal position within the health workforce, clustered into sectors of health according to lower social status and lower pay. On average, women health workers make 24% less than their male counterparts. And our research last year concluded that we estimate at least 6 million women, mostly community health workers, often the most marginalized in their communities, that are subsidizing global health everywhere. In keeping us all safe, women health workers themselves are often forced to adapt to unsafe working conditions without personal protective equipment, or if they do have it, it's poorly fit for women. Women health workers routinely experience abuse, sexual violence, and harassment from male colleagues and patients. This only gets worse in times of crisis. And finally, women do not have an equal say in decision-making for health systems they largely deliver. Although they are the majority of the health workforce, they only occupy 25% of the senior leadership positions. It's high time we recognize this is not only unfair and disproportionate, it also has a cost. I urge you to read our great resignation report, which is being launched next week. We have physical copies here with us today, which explains why the significant numbers of women health workers are leaving the sector. In 2021, we launched the Gender Equal Health and Care Workforce Initiative, which we co-lead with the government of France. The initiative, as its title suggests, is a high-level political initiative driving gender equity for health workers everywhere. And to date, we have over 50 partners that have signed up, including 18 governments. I'm pleased to say that many are in the room today. Please come on board and work with us to achieve a new social contract for women health workers based on equity that will provide economic justice for women, a stronger foundation for health systems, and disaster risk reduction. Thank you. And I would like to now hand over to Dr. Maria Nera, or actually, I'm sorry, it's going to be to Natasha Laporte from IDRC, who will lead us through the discussion.
And thanks everyone for being here with us. It's such a pleasure for us at IDRC, Canada's International Development Research Center, to co-host this session today with Women in Global Health here at the, can you hear me? Not so much. Here at the World Health Summit in Berlin. Really, thanks to colleagues from both organizations that have helped to make today happen, and for all of you for being here, our wonderful speakers as well, for making the time in your busy schedule to be with us. I would just like to say, before jumping into the heart of our topic, that I would like to acknowledge the territory on which we stand today and our generous folks here in Germany. And being from Canada, I'd also like to acknowledge the territory where I come from, and which is also home to IDRC's head office. And it is situated on the unceded territory of the Algonquin and Anishinaabe people, whose lands and waters will now Ottawa date back to time immemorial. Indigenous knowledge is strongly linked to the land and to the ways of life. And as an organization supporting and sharing knowledge in Canada International Week, this acknowledgement means reaffirming the value of local and Indigenous knowledge. Our acknowledgement also aims to recognize the history and experience of colonization. There's a lot of work that remains to be done on the path to reconciliation, including through decolonizing knowledge. So this is a reflection of our commitment to continue to support and honor Indigenous and local voices. So at IDRC, we believe in the power of research and evidence that is locally generated and championed to address knowledge gaps. This is why we fund high quality research that is led by low and middle income country research institutions. And we share the knowledge for greater uptake and use, and we mobilize our global alliances for a more sustainable and inclusive world. So as part of its global health programming, understanding climate change impacts on health, especially on those who are impacted the most, is really a priority for us at IDRC, and we think that it ought to be a priority for the world too. As you'll hear today from our seasoned experts, women have disproportionately suffered the impacts of climate events on their livelihoods and their well-being. And at the same time, they've been the ones at the front lines of emergency responses in times of crisis. So the nexus of climate, health, and gender may feel relatively new in some circles, the research community and policy agenda, but we want to emphasize here that for a lot of contexts, these crises of health and climate have been recurrent for almost 3 decades or more, and have become the norm, as we will learn from Ms. Zarari, and we'll share some stories in Somalia. In other contexts, women living in fragile environments have proactively participated in designing nature-based solutions to maintain healthy environments, such as the case that Ms. Carol here will share with us from Argentina. But have faced important challenges in their implementation, and this is in part due to adverse sociopolitical norms still facing us. So there are also multi-sectoral, global, regional dynamics at play in crisis response, and it is also important to consider and strengthen, as we will learn from Dr. Wanis and her experience working on One Health approaches in West Africa. So to conclude, gender equality and inclusion with a focus on intersecting experiences of vulnerability is central to all our research programming at IDRC. And believe this is not a nice thing to do, but a must do. It's really a public health imperative. So in this view, we really promote the life course approach to documenting the women's experiences on the front lines of crisis. Every age group suffers, they suffer differently, but also every individual of any age can be a leader. So if they're giving the means to, and we very much hope to work with you in bringing this vision to life. So without further ado, I wanted to introduce our wonderful moderator, Dr. Nera, who's with us today. She doesn't need an introduction, as Rupa has mentioned, because she's been very active in the summit in the last few days, bringing really the issue of climate to the fore. Unfortunately, Dr. Nera had to step out for a few minutes, so I will still introduce you, and feel free to leave whenever you need, and welcome to your back when you're ready to come back. But also wanted to mention that although this session is not live stream as part of the session through the main program as a side event, we are recording this session and we want to make it available publicly afterwards. So for the benefit of the people that are online too, I will formally introduce Dr. Nera. She's a director of the Department of Public Health and Environment at the World Health Organization. She brings 30 years of experience in the fields of disease prevention, control, eradication, and a rich career in various positions at the WHO, in the United Nations, and in advisory roles in multiple LMICs, including in Mozambique, Rwanda, El Salvador, and Honduras. Between 2002 and 2005, she was president of the Spanish Food Safety Agency and Vice Minister of Health and Consumer Affairs in Spain. And among other distinctions, she has been awarded La Médaille de l'Ordre National du Mérite by the government of France. So Dr. Nera, a warm welcome, and thank you so much for bringing us today.
Thank you. Thank you very much for this very nice introduction. Everybody calls me Maria, so please don't call me Dr. Nera. And I would love to be among women and the very brave gentlemen that are bravo for you. I've been working on public health for a long time. Yes, I realize it now when you mentioned the number of years. And I've been working on very difficult situations, unfortunately, because when I went to Mozambique, it was a country, it was quite peaceful. It wasn't a conflict, and then they signed a peace agreement. When I went to Rwanda, it was a very peaceful country, and then unfortunately something horrible happened. And when I worked in Central American refugee camps, always situations very, very challenging, very much at the limit. And I saw incredible things done by women. So it's not because I am a woman that I'm convinced that women in public health and in global health will have an incredible role. When HIV/AIDS started in Rwanda, you can't imagine the solidarity that I saw there. Women taking care, very poor women. I mean, women with a very, very low income and taking care of 6 children of a brother, a cousin, or somebody else. I saw them as well on having solidarity during war situation. I saw them as well, and this is where I learned about the difference and the inequities on women and male health. I learned it because we went to a refugee camp in Saipe in Congo, and at one point it was a massive return of all of those refugees, displaced people. And in 2 days, 1 million people moved back from Saipe, from Goma to Rwanda. And we put some sentinel health centers to check and take some data about the diseases, the injuries that were occurring and all of that. And somebody from the team asked me, do you want to register by gender? I say, no, we don't have time. There is no point. I mean, and then I realized that you need to register by gender, because what a coincidence. We have only male and children. And I said, well, why? I mean, the women are not getting sick or what? No, it's not that. They were giving priority to their children and to their husband. Maybe they were not giving priority to them, but they were taking it anyway. So, and I saw that. And I saw as well many, many times in Africa and other vulnerable countries in which I've been working, that if the salary, if every month there was some money getting into the house, And it was the woman, the one administered, those children were going to school, and those children were having at least the food and clothes. So again, nothing against a different type of economy, a masculine one, but obviously we have a role. What I learned as well on this career on public health and global health is that there are many women on global health, but they are the less on the important roles. And this includes even some international organizations where, of course, now we are a big number of women and we have responsibilities, but not always have been like that. The other thing I would like to say, and this is off the record, but you can share it if you want, is that we need to learn first to appreciate our own role as women in global health and be convinced of what we are doing. Because if we are not convinced, we will not convince others. And sometimes we are not proposing ourselves for this type of roles because we are not convinced that we can do it as good as a man. And that's quite, I mean, with the woman I'm working with, when you have a position that is advertised, a promotion, many times you see men applying without any doubt, while the woman will come to me and say, "Oh my, what do you think? Should I?" Why are you asking me this? Why should I? The other thing is when they start a career, a professional career, and then they want to be mother, and I mean, they have a private life as well, they start to panic as well. We start to panic, say, I don't know whether I will be able to do both. Please stop with that. Pass the message to the young generation. We can do everything, and we can do it very well. And we don't need to demonstrate that we are better or worse. There is no need to demonstrate anything. And please be yourself. We don't, to be good, we don't need to be men. Come on, we are contributing with something very special that we have, and we should be very proud and very convinced of, and we should not be afraid or ashamed of proposing ourselves. I don't know why, when a woman proposes herself for a position, she's very ambitious. Did you ever heard that from a man? I never. I mean, one of the Kennedys, sorry, do I have 1 minute?
Yes.
I love this anecdote. I love this anecdote. I have the opportunity to meet one of the Kennedy's family, a woman. She's on, I forgot her name now, it's okay. She's now in her 60s probably. And she told me that at one point when she was 40 something, after having 6 kids, she decided to go into politics, being a Kennedy, you know. And then the day she decided to run for a position, she put some lipstick and very short heels and all of that. And that day in the newspaper, the only description about her candidacy was about the shoes she was wearing. And then she had an interview with a journalist, and the journalist asked her, wow, you are a mother of 6 kids. Don't you think that this will be difficult to, you know, have your career, professional career as a mother of 6 kids? Yeah, Mark Kennedy, all my brothers, father, everyone, they have at least 10 kids. You never asked them this question. Why you didn't ask this question to my brother, to my uncle, to my father? They are all fathers of a lot of children. You never asked them this question. Why are you asking me this question? You want me to feel guilty? No. And you know what? The journalist was another woman.
Yeah.
That's very painful. So please be a nice mentor with other women. Be convinced that we can do a very good job. Don't prove anything. We don't need to prove anything. Dress as you like. Don't accept anyone telling you that if you want to be a professional, you need to be extremely stupid. No, you can be a beautiful woman, very nicely dressed, like you are all, and still be a fantastic intellectual professional. I think so. Anyway.
If I can put you on the spot, so I'm going off script, but I think she's off script a little bit too, so I can do this. We know each other from my student days, and she might not remember, but you must know I also became a new mom recently, so I did go through the panic. But one of the things we hear is that women cannot lead in crisis. And as the climate crisis is happening, we already saw in COVID-19 pandemic, that women were sidelined. The numbers show it. That COVID-19 task teams that formed, a group from Women in Global Health researched 114 task teams. 85% of those task teams were majority men. And there were entire task teams that had 20 representatives. I was in the city where this took place, which was Washington, DC. All of those 20 posts went to men. And women were sidelined, women ministers of health. We have incidental testimonies. And so how do you ensure that women who are at the front line of the crisis, whether they're experiencing it, whether they're the health workers themselves, don't fall free to this narrative that women can actually lead in crisis, and they have the right to lead? Yeah.
If somebody tells you that you cannot lead crisis, send them to me. I will be very, very pissed off. And I've been leading crisis in many circumstances. I was 27 years old. I was working on a refugee camp, and with my 27 years old, I was giving orders to plain men about what to do on a cholera break, on organizing a campaign for maternal health and vaccination and everything. So if I can do it, certainly you can do it, but you need to be convinced. If you are not convinced, we can be our biggest obstacle, you know? And I don't know whether it's because it's in our DNA or because of our cultural education. I don't know what is there, but it's not just to telling others that they are not inviting us to the panel. Sometimes we are ourselves not saying, hey, I need to be on that panel, and I can do it as somebody says, and I am already doing it. My experience, put a woman to lead a crisis, you have 100% of success.
There you go. That's the proof. Anytime anyone says it.
I don't, anyway, I'm out of script. I have to talk to this. So being a woman professional means as well to be disciplined. So I will be disciplined now. And it's a great, great pleasure to moderate this panel with three extraordinary women, because every woman is extraordinary. Are you convinced? Good. So I have from Argentina, hola, Emilia Carro. She's the president of the Women Global Health in Argentinian chapter. Mr. Carro is the CEO of the GD Foundation, which works towards the provision of equitable access to high quality digestive health in Argentina. That sounds good. By overcoming social, cultural, and economic barriers from the country population. So you will hear a lot what that means, overcoming barriers. And she's a specialist in medical genetics, not bad, and former president of the Sustentarte Foundation. With your permission, Emilia, I will stop here in this event, but you will share more later on. And then from Argentina, we go to Somalia, and I have another beautiful woman smiling and convinced that she's a great leader. So we have Ms. Ayaan Arare, who is a representative of the Women in Global Health in Somalia, which is not an easy one, I suppose. And she's the global health expert and a senior technical advisor to the Somalia government with a focus on health and climate change. So we work together on this one. We are on this battle together. And she has a particular emphasis on social protection, health and nutrition, which in Somalia is not an easy task. So I'm sure that she will give you very interesting insights as well. And then we move to Sweden, because we need a good balance from all parts of the world. And then we have Dr. Chadia. Where is Dr. Chadia? Oh. She's my colleague. Exactly, I was lost. Sorry, she's my colleague and friend, but I was looking for a Swedish. You see the stereotypes?
Yeah.
Good, red line, sorry. Chadia, my dear. And he says, you see, fantastic, fantastic. Only a woman can do that. We have Dr. Chadia Wanus, and she is the president of the, I didn't know that, of the Global Health, Women Global Health in Swedish chapter. And is, of course, a fantastic public health officer in charge now of a big agenda. Very interesting. She is very interesting and a very committed woman. I'm sure you will love her. So very, very warm welcome to the three of you, Sweeties, Somalia, Argentina. And now I will put you some questions on the table and then I will disappear because I need to go to Spain for 2 minutes and then I will come back. Very simple questions, very simple. Challenges, opportunities on climate change and health, your experiences, what do you recommend and how as a woman, as you say, how we can lead this climate change and health crisis that some people apparently is questioning whether we can do it or not. So who wants to start?
I can start.
Great, this is the attitude, fantastic. Please go ahead.
Well, tell you before starting that I worked for 10 years in sustainable development in Argentina. And then I came to the health sector. So I've been working for almost 10 years now. And 5 years ago, I started working with gender and health. And I will start reading something that I wrote, and it goes like this. During my involvement in sustainable development and climate change projects in the border region between Argentina and Brazil, I have witnessed a significant evolution in the intersection of gender, health, and the impact of climate change. Well, this is not true. I've never witnessed the intersection, and that's what I've been talking with my colleagues. I've been working for so many years in both sectors, but I've never seen how it was intersected. And in fact, part of my speech and my belief was to the government, hey, look at this, look at climate change, we have to do something about it because food provision is being affected, water sources are being affected, air pollution is here because of the fierce fires that we are going through. And that was part of my speech, that I never realized how this was not a climate, just a climate crisis, but a health crisis too. And being said that, another thing is that I used to work in the field in this project. And I had the opportunity of gathering data and maybe give a lot of conclusions and results here, but I never did. And I was the leader of those projects, but I've never realized how the importance of gathering data about gender and health and how it was getting affected. You know? So I will continue now because I have some stories to tell about that and some anecdotes. But I think that is a point, because if the people that is working and involved in the field in civil society and NGOs that are working there, there's a very big opportunity of partnering and working together on this issue. Not just the government, I mean, Minister of Environment and Minister of Health, but also in the civil society. There's a huge opportunity there. So the changing climate conditions in the region have brought prolonged droughts, and there were a lot of droughts. Imagine this is, I'm talking about the Amazonia, and highlighting the vulnerability of local communities. As water sources became scarcer, gender dynamics became more apparent. Women, historical caregivers in their homes, obviously, were faced with the task of traveling longer distances to obtain water, because there was not water in their farms, increasing their workload and exposure to risks. I saw that with my own eyes. Often their families and communities relied on them to ensure access to clean water, and were the ones with the burden of being the caregivers in those circumstances. And mainly because men in these circumstances of droughts, fires, are the ones that are leaving in order to look for jobs in other areas, and the women are the ones that are staying, rebuilding their communities. So exhaustion, helplessness, and anxiety became a reality in what I could witness. Despite the challenges, and there's a story there, what emerged was extraordinary resilience. And what I could see is that even though the projects that I was leading by the time were not gender-based, the women were the ones that became engaged. You know? A memorable example was that a group of women who devised a clever bamboo-based, nature-based, bamboo-based solution to address water management. It was not water management, it was like water source protections with nature-based solutions in their communities. They developed a project. However, when they presented their proposal, they encountered the resistance. You know? They presented the proposal to the local governments. This experience underscored the need to address not only climate change, but also gender inequality deeply rooted in power structures. Nevertheless, the women came together, found support among those who believe in their vision, that included us as the NGO leading those projects. Over time, the bamboo-based solution was implemented, marking not only an achievement in water management, but also a shift in the narratives of women's leadership in terms of production and innovation in the area. Well, my experience in Misiones highlighted the urgent need to address climate change as a health crisis too, you know, and how the interconnected is in the whole. Effective solutions require inclusion of all voices, obviously, but especially those of women, and interdisciplinary approach that allow us the development of the area. And well, I have some other things written down, but what I wanted to transmit is that it's very important to start working interdisciplinary because we always tend to, or well, I will say for myself, I always tend to work in the project, in my shelf, in my space. And sometimes there's so much that we could do or could have been done, just if we could have perhaps this meeting earlier, you know? And well, so that is one thing. And the other thing is that things are already happening there. It's very useful for all these vulnerable communities that we as health sector start realizing the importance we have in their circumstances, because this is not just climate crisis, but a health crisis. So well, that is my first contribution to the table.
Thank you so much. Thank you so much, Emilia. I will just take a little bit the lead of the moderator while Dr. Nera is outside for a little bit. I don't want to intervene too much because I really want to also have an opportunity to engage with this beautiful group that's here. Just want to thank you so much. And I already see some of the difference between what Maria said earlier and what you said in terms of experience in the field, and then missed opportunities to gather the important data and how we learn from that, and how this opportunity to come together and discuss really is a catalyst in changing our views, our paradigms, and doing things more comprehensively. So thank you so much for sharing that. So much. I will now give the floor to Ms. Arare. Ayan, please, over to you for sharing some of the stories from Somalia.
So thank you so much, first of all, for inviting me in this very important panel discussion. I'm very honored to be here first time World Health Summit to share experiences from Somalia and also learn.
I know it's hard. I know it's hard. I don't have a strong voice, but please try to with me.
Okay.
And speak a bit louder so that
I will try my best. Yeah. So thank you so much. So Somalia, for those of you maybe who don't know, is a country situated in the Horn of Africa, and a country that is actually currently facing with web of challenges spanning from social, political, and developmental circles. These difficulties has been significantly compounded by the looming threat, the global looming threat of climate change, despite Somalia's minimal contribution to the greenhouse gas emissions that cause the climate change disasters. Over the last 3 decades, Somalia has experienced 31 climatic disasters, more than 12 droughts and 18 floods, pushing the limits of adaptation methods. And then these calamities have internally displaced 3.9 million people, with over 1 million people only displaced last year. So I was here last October in Berlin, advocating and knocking the doors for the German government, asking them support after 5 consecutive rainy seasons have been failed in the country, and that we were actually facing a really famine. The country was facing famine. It happens that I'm again here today, and my country is in the middle of the El Nino flood. So we are either in between too much water or no water. These climatic harsh realities has forced our people to abandon their rural lives. It has resulted in displacement, loss of livelihoods, food scarcity, malnutrition. Currently, half of the Somali people, with 7 million, are food in school, while more than 10% of our population are displaced. So we are in the middle of despair and hope, not knowing what's even causing these disasters. In terms of the health consequences of the climate change, climate-related droughts and floods disrupt the rainfall pattern, has led to food shortages, resulting in higher rates of malnutrition, especially among women and children. So the people who have been affected by the climate, 80% of them are women and children. Reduced water availability and flooding also forced communities to use contaminated water, increasing the risk of waterborne diseases like cholera. Access to healthcare is also disrupted with climate-related disasters, damaging healthcare infrastructure and disrupting essential medical services. With regards to women, as I said, Somalia is facing complex web of challenges. So it's also ranked as one of the most gender equal country globally, with 56% of Somali women being illiterate and 36% of them get married or married off before the age of 18. These gender disparities has been exacerbated by the climate change. And it also all these developments lead to inequalities in healthcare access, inequalities in education, inequality in job opportunities. So the climate disaster in Somalia, there's a traditional role that women are being asked to eat on school meals. So during disasters and when the food is, there's a shortage of food, it puts a risk of pregnant women and young women as well. Traditionally, I really agree with my sister Emilia. Women are also assigned for the fetching water. So during droughts, it puts women to travel very long distances and putting them at risk of violence, and at the same time disrupts girls' education. These circumstances, sometimes what happens, disasters kind of cause child marriage as a coping mechanism. So despite these challenges, Somali women, again, I agree with my sister Emilia, when crises like either civil war or flood or drought occur, men always migrate. So it's women that's been left behind and are very close to the community. And that's why more than 70% of the healthcare is delivered by women. For them, is they see as a commitment for their communities and for the health of their children. So during the times of crisis, hospitals become overwhelming and with overwhelming influx of patients, not only looking for health services, but also looking for humanitarian services. So women at community level has to be different stakeholders. They act as humanitarian workers and at the same time provide the essential medical services. with very minimal incentives or mega wages for their commitments and for the services. Despite delivering majority of the healthcare services, their decision-making power is very limited. So what do you see all the people working at health facility, like if it's a nutritionist or a nurse or a community health worker, all of them are women. But as you go up into the hierarchy, even at district level, district officers, these are men and decisions are made by these men, which again affects healthcare outcomes of the community. A story from the field that a nurse shared with me, healthcare services is hugely funded by the international community in our country. So when disaster hits, whether it's a flood or drought, most of the funds is shifted to the droughts, to the emergency. So they scale down the health services, starting cutting the salaries of the lower level salaries of the health workers. So the real stories in the field reveal that frontline health workers endure the mess of these salary cuts, even though they deliver most of the health services, and at the same time working as humanitarian workers in the field. These decisions are typically made by male leaders who may not know what these great ladies are dealing with. So I'll share more stories and maybe opportunities. Sorry, I've been kind of telling you a sad stories, but I'm willing to talk about how do we shift this into other opportunities as we go through. Thank you so much.
Please don't apologize for sharing those stories. That's exactly what we're here for, and what we're looking for as a community to be aware and to be there and to know how to respond. Thank you so much. It's a very comprehensive overview of the massive amount of challenges that you're dealing with in that 4 decades. So I think it's very important for us to consider that. And we will come back for a short round after Dr. Chadia for your stories on, your experiences from the field and some challenges, obstacles that you may have encountered there. And after we will come back for positive take on this opportunity and solutions that we'd like to put forward. So please, over to you.
Thank you very much. First, I'm very glad to be with you. Of course, my network, my colleagues, and to see also new faces joining us. I have like 20 years plus of experience in health emergency prevention, preparedness, and response. So I will talk about another kind of disasters that we are facing, which is pandemics, which we all lived through in the last 4 years, and we are still in the pandemic, although we officially announced that it's over, but actually we still have cases and we still have death because of COVID-19. And what we are trying to do is to make the link between the pandemic happening and the drivers of risk, including climate change, biodiversity loss, land use change, how we destruct the habitat, how we become closer to wildlife, and what kind of exposure and vulnerabilities we have because of this. And of course, because mostly women are responsible for finding food and finding woods from the forest and feeding their children and taking care of livestock. They become more exposed to the wildlife, to the animals, and become more exposed to the viruses, of course. We know for sure, I worked for as senior policy advisor for the UN on Ebola response in West Africa. And we witnessed firsthand how this jump happened from the forest to the humans. And if we are to say we don't want people to go to the forest, we don't want them to like have bush meat or hunting or cultural practices, we have to provide them with the alternatives. And this is because of climate change, because of the droughts, floods, and others. They don't have access to nutrition. They don't have access to food. So they are food insecure. That's why they have to find solutions. And one of them is to expose themselves to higher risk. The other part also is about the women when they are infected. The access to care is less than the men. The men will go faster to the health services than the women because the women they delay access because they think of their family first. I have to take care of my family first, and then I go later. If I have to pay upfront, maybe if I pay, I will not be able to feed my family. So there's this compromise, and here what should we do? Prioritizing the family, prioritizing the kids, and the children, then herself and her health. And that's why we have more mortality in some cases than in the women. Now, on the healthcare side, the frontline workers, we witnessed that the issue of protective equipment that you said, Ruba, that they were not designed for women. It's kind of unisex, like you go to the supermarket and you have this sign unisex, anyone can use it, but actually it's difficult to practice medicine, and especially in this very critical situation where the infection is very high, you need something that you are comfortable with, and you can take it off and put it on quickly without exposing yourself to the harm or to infection. So another part also is about leadership. Starting from the community up to the higher level, when we faced with Ebola or we faced with COVID-19, Ruben, you mentioned the task forces for COVID-19, but also at the community level. We know that women are strong agents of change. They take care of the sick, the elderly, and everything. But when the decision-making counts, it's the men who are stepping forward. And when we also have compensation or we provide financial aid, it's the men who receive it, not the women. So in our way of working, we have to think about these gender issues and ensure that we have the women represented in all of our interventions in the community. I know for sure that also access to information is not easy. Access to credit if you want to do some activities. We know for sure that we don't have enough data. Like Maria said, we were first thinking, do we have to register if the sex or not the gender? But actually it's very important because there are some biological differences, but also there are social and cultural differences that affect the outcome of the disease. So we have to take it into consideration. Another issue with the female frontline workers that they face discrimination from both the patients and from their colleagues. From the patients, some of them, they said, I don't want a woman to treat me, I need a man. Because they perceive that men are more capable than women, especially with these infectious diseases, hemorrhagic fever that are scary. So the men are more capable. And they were demanding to see a man, not a woman. Another issue also is discrimination from colleagues. They have to prove themselves that I am capable of doing this, and I have to work extra hard and work extra hour and shift to prove that I am on equal footing than my fellow doctors or nurses or other colleagues. And then this issue of work and life balance, of course, you cannot mention it. Otherwise, we are weak. What do you mean that you have to go home to take care of your family? No, you have to be here. Although the shift has ended, but you are expected to perform more. And then because of that, we have a lot of cases of burnout. The mental health, the psychological effect on women, it wasn't factors also in our intervention. We didn't provide for them. And then we had to later say that this issue has to be in the center, all of our interventions around pandemics and the linkage between pandemics, climate, and biodiversity. Thank you.
Thank you so much. I really think it's important what you mentioned, especially at the end there, and linking it to mental health also of our healthcare workers. And it just reminded some shocking images during the pandemic, you know, while we were seeing a lot of the women doctors were really badly affected by what was happening in their everyday lives in the hospital. And some of them committed suicide, you know, had a really bad impact. So I think this is a topic that we'll never talk about enough. And on this second part of the panel, where we want to look forward and we want to learn from these circumstances and look at the opportunities and look at some of the solutions, how to overcome the barriers that we're talking about up to now. Who are the allies? What are the mechanisms that we tested that, you know, could really be scaled up and with what it means, with what type of support. So I'll turn again over to you for a quick round if we can, so we can have some time to engage with our amazing audience here with some roundtable discussions after. I'm turning over to you because you seem ready to go. So, you know, there's no set order here, but Emilia, please go ahead and share with us what opportunities, recommendations you see for us going forward as a team.
Well, I said it already or gave the introduction. I think that policy integration could be an opportunity. What I mean by policy integration is the integration between climate action or environmental agencies with health ministers or agencies too. That I think it's a great opportunity of working and of awareness and not doing twice the same job, you know. People who is in the field, they're already there working, gathering information that we didn't gather before. And well, that could be a good opportunity of working, like environmental agencies or ministers having like a group who's participating in the Minister of Health could be a good opportunity. I know that Kenya is already doing that. And because they as Somalia, they have a lot of climate crisis and they are doing that and it's working well. So that is for me a good opportunity. Among probably I'm trying to empower women and still working on the gender gap. That is another issue, and it's have to be avoided from everywhere. But in this particular issue, this could be a start.
Yeah, thank you so much. So before I go to the solutions, I think I need to kind of blame a bit the global north that have caused the impacts that we see at country level. So to tackle the climate injustices at country level, we must first recognize climate inequality and injustices at global level. The nations that have contributed the least are often the ones that suffer the most. while climate change impacts all, it affects us all, but the wealthier nations have the means to mitigate and build resilience. In contrast, developing countries, when we say Africa or the countries that I came from, Somalia, contributed maybe 0 to very minimal to the greenhouse gas emissions, but we bear the brunt of climate change's consequences. As I said, we are either in a flood or a drought. And this is what affects our health system, exacerbates the gender disparities that I have just discussed. The economic growth that have been experienced in the developed countries, it has came through the carbon intensive industries, and the billions of dollars and trillions of money that's been made by the fossil fuel companies had a significant and far-reaching effects, and substantially has contributed to the greenhouse gas emissions. As a result, what we see now is the consequences of the climate change, such as the extreme weather events, rising sea levels, disruption to the ecosystems, and have hit the developing countries with greater intensity. So I work with the government and I always go to the climate discussions. So I'm going to share with you some of the background discussions of the climate change. If we want to transform this, we must make the wealthier nations accountable, and we need to advocate for global north to pay for the losses and the damage that have been caused by the climate change. I was there at the last COP27. The global north has promised that they're going to be paying 100 billion every year to kind of support developing countries address or adapt to the climate change consequences. However, research shows only 24% of these funds has been achieved. So far, the rest is kind of overestimation, and what's more, significant portion of this money is loans, which puts governments into more kind of debt, and again hinders their access to developmental funds. So if we really want to address these climatic realities that we see in developing countries, the global north must honor the $100 billion commitment in a manner that's also easily accessible. A great challenge that all countries are having, accessing to this climate funds is really, really challenging. And it takes like 5 years while the climate reality is happening in front of us. While advocating for climate change, I am not saying as Somalia as a nation or as Somali women, we are just sitting there, the wealthier nations to rescue us. We are also doing our bit. Our women are now struggling to kind of think about how they adapt. But adapting to the climate change means huge investment, and it's not something that countries like where I came from can actually invest. Gender inclusive approach are also essential for addressing climate change effectively and promoting a more sustainable and equitable future, given the roles that women do, which spans from like community resilience, resource management, education, and entrepreneurship. So that's the blame part. What works? Some of the research that really work in Somalia, for me, I just go very direct, not to the government. We need to, if we want to transform women fundamentally, we must start by initiating, we need to kind of start from the national legal systems. We need to protect the rights of women by if the whole world wants us to change and we are not ready, we are not protecting women in our legal system, then we cannot do anything. The only way we can do that is supporting local women, educating them, and actually advocating them and raising their awareness that they need to take the seats. So for us as a Women Global Health Somalia, what we do is that we start by ourselves. We push ourselves to kind of work with the government. We sometimes go to the ministries and, you know, all the governmental offices and say, we want to work with you. We want to volunteer with you. We don't want any salary because we want to kind of influence the policies and strategies. We want to see our sides are there, that we want to see we are also protected and we are part of the decision making process. So supporting local women like Women Global Health Somalia is the solution to kind of transform the challenge that I mentioned to opportunity. Advocating for implementing gender responsive policies, legislations, empowering women to actively participate in disaster risk reduction, climate adaptation planning, all these will be very helpful to tackle the challenge that I have mentioned. Economic opportunities for women, as I said, women are labor workers. They are the ones who work at agriculture or livestock, but then ownership, land ownership, or economic, the power to kind of economic ownership is very limited. So we need to support them economically. Finally, I would say the climate crisis is all interconnected. The action that is happening in Somalia is affecting the North America, and the developments that's happening in the North America affects the rural Somali women living far rich hard-to-reach areas. So it's very crucial, and it's the right time now that we all unite jointly and confront the climate challenges, prioritizing involvement of women in our actions. Thank you so much.
Thank you so much.
Thank you. Okay, for the solutions, I start with the bigger picture. We have to bring those sectors together. The people who are working on climate change and who are working on public health, animal health, and the environment to work together. And for that, we are advocating for the One Health approach, which is an integrated, unifying approach to bring those sectors and disciplines behind them to collaborate and reduce the risk of pandemics. And about the gender issue, how to factor this, how to factor in the gender issue in this work on One Health. We start with the global plan of action that the four organizations call ourselves the quadripartite for One Health, which is WHO, FAO, UNEP, UN Environment Program, and the World Organization for Animal Health. We developed this joint plan of action, and we made sure the women on the drafting team that gender is there. And this has to be translated now into national action plan at country level and also regional plan. And we will support countries to ensure this is happening. And including in this to understand if we are doing any intervention to reduce the risk or to advocate for integration of environment into health, what kind of impact, gender differentiated impact, these interventions will have. And we have to document it and share the lessons there with our community. We need more data on gender, we need more evidence, indicators on the impact of gender. We also came together and with my colleague Anya is here. We were in the One Health Global Congress last year in Singapore, and we witnessed this phenomenon of all male panels. And when we approach some of the organizers or colleagues, they said, "Oh, we couldn't find qualified women to can you actually this excuse?" And then we came together and established Women for One Health network. And we started with the doing a roster of women by expertise in this regard. Some of us working on animal health and global health or climate change. And we provided them with this, and we also wrote to them an official letter about this is unacceptable now in this age to have this as an excuse. And we are talking about the academic and scientific community. We also want to do more for our regional networks and to collaborate with the other networks working with global health, like the Women in Global Health. We have also Women in Biodiversity that we can collaborate and join forces to ensure that agenda is really reflected. I know that some of us are not aware. Awareness of gender inequality is not high, even among ourselves, women, but also among policymakers. So we need to do more kind of advocacy, policy briefs, and share with them the information. And for example, I was surprised we did a study in Southeast Asia about gender in veterinary services. And in 2015, we have zero women leading vet services in the whole region. And if we don't know this information, we will not work to mitigate it and change this perspective. We are doing also effort to have more online training on gender sensitive project development on one hand. And we are also in our organization developing gender policy and ensure that we lead by example. So if we are advocating for gender, we should ourselves be gender responsive communities. Thank you.
Thank you so much. This was really informative, and I can hear the passion, the commitment to everything that you shared. We're pleased to have Dr. Nera Bahia back with us, just in time for opening up the discussion to the group here, hear your reactions, your stories. So I would just open it to the floor. If you want to say a few words before we do that, please do go as well.
Thank you. I miss very strong statements, I'm sure, but I have a question for all. How many people here knows what is NDCs? Not NCDs, huh? NDCs. Who? Okay. Well, you are not to the Can you tell us what is an NDC, please? Yeah?
Nationally determined contributions. It's where the countries commit or lay out their plans for how they want to work on climate change and especially mitigation.
Okay, this is my first signal. Please make sure you know what the NDCs are at the country level. If you want to work on climate change and health, we need to be aware of what the NDCs are and how we can make sure that we will incorporate our contribution to that. So yeah, it was just a provocative question, but now it's open for your questions. So over to you. You need to speak NDCs, remember. Not only speak English or Spanish or Egyptian, but NDCs as well. It's an important language these days. Yes, please.
All right. Hi, everybody. My name is Marian. I'm doing my second year of master's in public
Marian,
health.
you need to.
No one can hear me. I'm
There is no
very loud.
microphone here, so you need to shout.
Sorry. Maybe I sit up. Hi, everyone. My name is Marian. I'm doing my master's in public health, the second year. So my question is related to basically climate change and the risk reduction. But in my country, we don't really have like a lot of discussions on waste management. I'm from Cameroon, sorry if I did not mention. We don't really have a lot of discussions on waste management, especially through recycling. So I know we have the women in global health there, but recycling is something that we already have the problem. We have the bottles in the sea. There are some places we cannot go, we cannot swim and everything. We can't even play there because of how bad we are suffering from the bottles that have been coming. So I'm just curious because I know recycling is very costly, I know it's expensive, but that's a problem which is already there. While trying to solve things which are still coming, what do we do with those things? So I just want to know, like, is there something which is going on which I don't know? Or what exactly do we think about recycling in order to manage some of the waste we have right now? Because I really like here in Berlin, my friends put in the bottle here, put in this there. I don't have that back at home. We just throw everything in the same place. And I think many other African people here and maybe other countries can agree with me. Thank you.
I have an idea. You are a medical student. You need to do a master thesis, don't you?
Yes, I'm
Why
doing
you don't do it about that? No, seriously, you propose to your community to start to recycle, you organize a training, you organize an advocacy, raising awareness campaign, something, just an idea for you to consider, and you go back to Cameroon.
It's work in progress.
Should we take more questions before passing to the panelists? Please introduce yourself.
Sure. Hi, everyone. My name is Bonnie Berg, and I'm the Executive Director of the Global Initiative on Helping the Economy at the U.S. Chamber of Commerce. So my question is, thank you, everyone, for your remarks. When we were discussing some of the solutions, you talked about the integration of the more environmental-oriented agencies with the health agencies, but I didn't hear the integration out of ministries of finance. And I wonder if there's been more discussion about how do we integrate ministries of finance, also actually ministries of industry, of trade, because if you make the investment case, I mean, I think everyone knows investing in women is a best buy. If you make the investment case for putting more funding towards climate mitigation with a focus on gender inequity, then I think you can sort of shift some of the power dynamics that you're seeing in the main examples that we talked about.
Do we take another question and then back to the panelists? Last question? Yes, please, in the back. Okay, shout.
Gladly. I have a loud voice. So, hello everyone, my name is Mira Khalil. I'm one of the co-founders of the Women Global Health chapter in Egypt. Amazing as always, panelists. One question I've been asked that I'm very curious to hear from all of you, or perhaps some of you on this. I've done a lot of work specifically in Emerald region on scaling up health systems resilience, particularly in a region where 2/3 of countries are facing emergencies, multi-hazard emergencies all at the same time. So the question that we are posed in building up health systems resilience, of course, bringing communities in, how do we bring in the gender lens? And I think for so many of us who are maybe not gender experts, but learning to become gender experts in the room, what does that mean in practical terms when we're talking about operationalizing a gender transformative approach to health emergencies and disaster management? Thank you.
Wonderful. Who wants to start? We have three very interesting questions. Charlie, I see you're ready. I should take a little pen.
I will take the finance.
My dear Charlie, I'm from Sweden. Now I learned that.
Yeah, I think the finance question, which it's really very important to make the investment case. And for that, we need to work with the finance ministers. We have an experience now through the health finance task force under the G20. But it's not enough. We need all the countries to have this kind of collaboration between the two ministries. And monthly, I know this task force is working on health emergencies in particular, but also we are trying to touch upon the risk drivers, including climate change and environment, and try to see how we can change the narrative a little bit there. But the gender issue, I agree with you, it's not there yet. So maybe this is something that we have to work on in the next presidency, which now Brazil is taking on.
Just gonna add to the integration of gender and health into the NBCs. That's something that we are working on in Somalia. Before we did not have a health component in our NBCs, but now we are doing and we are adding that. Gender was also cross-cutting, but then we realized if we see cross-cutting, then there will not be specific funding for that. So we're making a standalone component as well in the action plans. For me, my work is more on climate justice and climate finance, kind of advocating for the global north to pay for their loss and damages. I don't work on mitigation, it's more on adaptation, because that's what we do in Somalia. So Ministry of Finance always lives with this business, so we're asking for finance. Yeah, I'm not sure if I understood the question from my sister at the back, but yeah. Thank you.
So I have one thing to say for the two last questions. Sorry about recycling. I can say anything about that, but I agree that integration is, when we talk about integration, is not everything, you know. But the thing is that working, what I meant about health and environment is that we are dealing on those issues, and that couldn't be by any chance not integrated. But then obviously finance should be part of the table, and it's very clever to say it out loud too. So thank you for that. And about the gender transformative approach, I think that the answer always is we need more women in leadership positions. It's simple to speak, but I think that's the answer. We should work on that from different sectors.
It's not so much, it's not so much a question, but also a reply. So in terms of, so two things. Before I was heading, healthcare was our town chapter for Europe for 10 years. And so we have a network for global green and healthy hospitals. There's lots of information and lots of training. And one of them is specific for waste, for instance. And also there's, the nurses are very active in advocating and educating themselves. And that's also an occupational hazard issue for needle pricks and other injuries, because they're the ones that are first exposed. So they have actually built national chapters and really educated themselves, because they have also the solutions, how to actually avoid injuries, etc. So I think that would be a very good way to look at. There's plenty of material. If you go onto the website, it's called noharm.org, you'll find it. And then the other thing, so in my current role, I work for GIZ in Germany, which is an agency implementing projects in 120 countries. So for instance, in Cameroon, you know, there are bilateral agreements and negotiations going on. So if you look at your own country and say that, you know, you want more collaboration with Germany in future, specifically on health, on waste, because that's a huge issue. And I know that we have waste and also medical waste projects in many countries. So I think, and that's happening in many countries where there's those negotiations and projects, etc. So I think it's just a matter of us exchanging information, and their solutions are already there, and empowering it by learning and doing and then speaking up. You become the expert and then you start to lead.
And we will take the last comment from our gentleman there. Please introduce yourself. Bravo.
Thank you so much for the opportunity. My name is Kazim Balogun. I work with AL Africa, based in Nigeria. I just want to build on what Elia said about gender transformative approaches. I believe strongly that as we work to get more women on the table where decisions are made, it's also important to identify men as allies and, you know, sensitize them to become part of the decision in taking that important decision that gets us to that desired change that we want. Getting there is not going to be something that women will have to do alone, because, you know, as we work towards that goal of getting more women on the table, we still need to build on men who become the allies, and, you know, consider the importance of having women in, you know, at the table, as well as making sure that that desire that we want to see, you know, happens. I would have loved to see more men here, for example. You know, part of building that movement of men becoming allies, you know, for women change that we desire.
Okay, and we are about to wrap up, and before that, it is my great pleasure to give the floor to my colleague and friend, Dr. Amelia Tripolotu, and she will have, did I pronounce wrong? Say it. 3, 2, 1. Okay. Wonderful. And she is our WHO's Chief Nursing Officer, and she was the first female minister for health for the Kingdom of Tonga, and led the Tonga response to both the measles outbreak and the COVID pandemic. So I think we can pretend as well that we have a very large experience in public health. So thank you very much, and over to you for the closing remarks.
Thank you, Dr. Maria. And I want to say at the forefront, women can lead successfully in centennial pandemic and centennial crisis for the world and save lives. And I mean women, including nurses and midwives, and of course, healthcare workers. I am here as, with, direct, leadership and direct experience, from the ground. And, you have heard from our experts, and they are the experts on the field, Maria, and of course, the rest of the team. And I would like to thank them all for the expertise, knowledge, and perspectives from the ground. What I would like to contribute is contribute from my experience before I come to WHO. And that one is the importance of women leadership. A woman, and of course, all of you with knowledge and skills, with compassion and skillful in decision making, and I mean ethical decision making at the highest levels. I believe that women of today can lead in any organization and in any disaster, and of course, disaster risk reduction to save the population. You have heard the clear solutions from the panelists, and I want to acknowledge first that the challenges that they have shared are challenges that nurses and midwives face at the front line of care every day and during disaster management and during disaster risk reduction work. So we're talking about 20+ million women, majority are women around the world, facing challenges with violence, facing challenges with burnout, stress at the frontier. But I am somebody who would like to speak about solutions, and I hear it loud and clear from the team. And as I have mentioned, I'm sharing from my experience before, one of which I believe that we must be making policies as women leaders. One of the policy that we targeted was creating senior positions within the health systems. And I hear it from the panelists. As women leaders, we must create more positions for women to be able to have senior positions within the health system in order to better support the health systems to better respond to population health needs and ensure universal health coverage. In our two major disasters of the past, one of which was in 2009, it was only a nurse practitioner working at the remotest context of Tonga during a tsunami that killed 9 people. She gathered the communities, calling out for elderlies, engaging women and children, trying to save lives after the first wave. So a nurse practitioner leading disaster management at the frontier, of course, with the support of people on the ground. That was one of the reasons why there was an intention to create senior positions, including those who are working as nurse practitioners in remote contexts, to give recognition and value to the work that they do as they continue to deliver on routine and prepare for disaster. Second, during the pandemic, very early during the pandemic, one must strategically move quickly with the support of the whole team, including finance, to ensure there is a package hazard allowance, which was 25% of your salary, submitted to cabinet, and this was approved for healthcare workers, majority nurses and midwives and women, before nurses, healthcare workers take care of suspected and confirmed cases of COVID-19. When we had quarantine places and suspected cases later on during the pandemic, and Minister of Finance saw the spending in the millions, and I was kind of challenged that there is a lot of money spent on this package. But I told him that is very little money to spend to save the lives of the population. So as an allowance for our healthcare workers, very important as recognition of the work that they do. I want to also speak to what have been said about powerful men support, very important. I want to acknowledge here that my work I was very happy that during my journey, very powerful men will check on how you are doing. Are you having a rest during the weekends? So it is very important that we build alliances with these people. Next is that as I chair the National Emergency Committee Management Committee, I noted that women were kind of hesitant to contribute. The round table was approximately 80% women and the rest were women. So I will always ask for the women on the table to give their perspectives. But because debate will accelerate higher, one must be willing to debate all the way your position. So that is very, very important in the highest level as we are working together to save the lives of the population. We must debate all the way in order to ensure equity and we serve the most vulnerable population. Well, lastly, I want to say that there is a common concept that investment in women, it is an investment in our children for the future. It is an investment in the society, building a strong society for the future. So the work that we are doing together, and I want to acknowledge Dr. Rupa and her team for scaling up and continuing the dialogue and the debate with regards to empowerment of women. So important as foundation for success in communities and for the nation as a whole. Lastly, in Tonga, collaboratively rowing the way, we must come together with all our skills and knowledge and have the humility to work together as a team so that we can build a stronger foundation for women as frontiers of disaster risk reduction of tomorrow, like women in general, so that they can prosper and succeed in the future. I thank you very much.
Opportunity to close the meeting and thank all the participants, the panelists, and from my side, thank you so much for inviting me to have the opportunity to share with favorite people, which are home. I'm the mother of a boy, but and in fact, maybe Natasha and close the meeting. Thank you so much.
Thank you so much. I just have thanks for all our panelists and everyone that helped make today happen, for all of you for being so numerous in joining us today for this conversation, and we really hope to keep it engaging with all of you on this topic. Thank you for their answers and yours. Again, thank you to all. Thank you for moderating Marina and Natasha and all of our chapters members here and leaders. Here's the call to action simple. Let's really make sure women who are at the front line, experiencing the changes, addressing the changes, are valued and are seen as leaders. Let's really make sure that we don't have gender blind conversations as the climate crisis is unfolding itself. And I know there was homework given out today already by Dr. Nair, but I think there's homework for all one of us to make sure that as these discussions are happening at the national level, let's really make sure women are at the table and we are bringing a gender transformative perspective forward. So thank you. Women in Global Health invites you to stay connected with us, and we will continue the discussion. As you know, our chapters are already working on this. So thank you for the partnership to IDRC for making it possible to host this discussion today. Thank you.